Okay, so this lecture is on blood thinners, and we'll start the lecture with anticoagulants. Not all blood thinners are anticoagulants. Anticoagulants are not clot busters. In fact, they only slow down bleeding, make the bleeding tendency greater, and so it's more likely that that person's going to bleed. So they slow down and prevent the formation of more clot. But if you've already got a clot, the body's got to really break that clot down if you're on an anticoagulant. Some anticoagulants we talk about are heparin and Lovenox, some direct thrombin inhibitors, warfarin, which is also Coumadin or Jantivin, and then the 10A inhibitors. So Coumadin is the first drug that we talk about, and before we get talking about Coumadin, we have to talk about some vitamin K rich foods, because vitamin K is the antidote to Coumadin. Vitamin K interferes with the action of Coumadin. Again, it is the antidote of Coumadin. Foods high in vitamin K are kale, mustard greens, spinach, parsley, herbs, Brussels sprouts, kiwi, cauliflower, and cucumbers. The person that is on Coumadin should not have a variable diet in these. Changing up the diet with vitamin K rich foods can lead to improper bleeding tendencies in these people, and it can make it very difficult to manage Coumadin. So some common drug, food, and drug herb interference are: many antibiotics increase INR and increase the risk of bleeding while on Coumadin. You need to remember this. We measure Coumadin and how well it is working by the INR. For you and I and other healthy people, a normal INR is about 1.1. You can think of it as less than 2 is about a normal INR. However, Coumadin is a little different, so when we've got someone on Coumadin, we want them to have a therapeutic INR, not a normal INR. So we want their therapeutic INR to be between 2 and 3. Alcohol has a goofy effect on Coumadin, so don't ingest alcohol while on Coumadin. Vitamin K containing foods decrease the effectiveness of Coumadin. Ginkgo biloba and ginseng increase the risk of bleeding. Estrogen-containing meds can decrease the effectiveness of warfarin. Aspirin makes risk of bleeding higher with Coumadin, but the two can still be used together. We want to explore a couple of things before we move on, and that is the holding of Coumadin. So we watch the INR while someone's on Coumadin. And while someone's on Coumadin, we want that INR to be between 2 and 3 because that's the therapeutic effect that we want. So what we want to do is, if it's too high, like let's say it's 4, we're going to hold the Coumadin and contact the doc and or nurse practitioner, whoever the prescriber is for that person, in order to move forward in figuring out if we should hold it or not, and we will hold it, and we'll get an order to back us up. Moving forward, a lot of people get put on Lovenox if they have a DVT or if they've had surgery or on bed rest. So they get put on Lovenox, and Lovenox is a subcutaneous injection. It's given in the Lovenox love handles. It's given initially to inpatients and outpatients with the DVT, and then they'll start Coumadin, and they'll keep the person on Coumadin and Lovenox for a few days until that Coumadin takes its effect. The Lovenox works much faster, and so you get a therapeutic effect much sooner, but nobody wants to give themselves shots forever. So if someone needs to be on a blood thinner for any period of time, oftentimes they will then transition over to Coumadin so that they can take something orally. And Coumadin's effect will hit in a couple of days to a few days. And as soon as that INR is at a therapeutic level, then they can discontinue the Lovenox and just go with the Coumadin. These are the sites that you can use for subcutaneous administration of Lovenox. These are called the Lovenox love handles. So many anticoagulants have antagonists. Thank goodness. They can be some of the most dangerous drugs in the world. Heparin is something that we use in the hospital quite a bit. We use it as a drip, and it can also be given subcutaneously, although Lovenox is a more common subcutaneous measure than heparin. So heparin can be given IV. A reversal agent for heparin is protamine sulfate. The reversal agent for warfarin is vitamin K. Antiplatelets. So antiplatelets just make the platelets slippery, just like the ice on this road. So things like aspirin and NSAIDs, they can make the platelets slippery, and in that way increase the bleeding tendencies. So thrombolytics are altogether different than any of the anticoagulants. They are not anticoagulants. Anticoagulants and thrombolytics are different in that anticoagulants just slow down that clotting pathway and increase bleeding tendency, allowing for the body to actually break down the clot itself. Well, with thrombolytics, it's a little different because the thrombolytic will go in there and bust the clot up. So I like to think of thrombolytics as cleaning up the accident, just like a tow truck would. So at any rate, thrombolytics are among the most dangerous things you'll ever see in your life. One thing that it's used on is a stroke. Sometimes they can be used localized also, but one of the only systemic uses anymore are for stroke. TPA is the med that we give as a thrombolytic. It's a very dangerous med. You must have very specific training. And when you do, you actually do 15-minute neurochecks because it's such a high risk for a bleed. Before you can start it, you want to have all your IVs placed, you want to have your catheter placed, you want to have all of that stuff placed because anything that's invasive will cause significant bleeding.